I'm here to tell you about the relationship between domiciliary care provision and care home markets using a nice bit of data that is publicly available. This is work from a policy research unit, but it's certainly applicable to this data centre. So by way of an introduction, for those of you who don't know, the social care policy in the last 20 or 30 years has been increasingly moving to personalisation and providing care in people's own homes. And so as such, it's moving away from more costly institutional care to cheaper provision of care at home. And domiciliary care provision, so using domiciliary care rather than home care, so I don't start talking about home care and care home throughout to confuse you all. Domiciliary care provision in England has increased markedly over that time as social care policy has changed. And there are a wide spectrum of services available from a little bit of personal care going and helping you with shopping, going out to get your shopping, all the way through to living carers who are almost providing a service that is seen as fairly similar to being in a care home. But of interest to policymakers will be, what is that impact? What is the impact of increasing supply of domiciliary care on the care homes market? Is it having an impact? Does changing your focus of one, has it affected the market for the other? Okay, so for the rest of the session, I'll talk you over the theory and past evidence to kind of implicate on what we think is going to happen. Then we'll go over the data, then results, and then we'll have a bit of discussion around those results and what might be driving them, and then a brief conclusion. Okay, so we're expecting that there's going to be a substitution between different forms of social care. So that comes from economic theory. So with economic theory, competition between not necessarily direct substitutes will lead to a finite number of firms. So in other words, competition will lead to fewer firms. And as well as that, demand at the margins is fairly likely to be similar. So there are two main streams of funding source for care homes and domiciliary care. Those are self-funders, private payers who pay out their own pockets, and then those who are supported by public funding. So for self-funders, there is a direct choice. Do you get some home care where you're living, or do you move into a care home? And so that will be based on individual choice. The public funding is a little bit more tricky. There is, within the Care Acts, people are meant to get choice of social care service, but it will be dependent on the cost of those services. So someone who wants to have one form of social care may not be able to receive that form of social care if it's too expensive compared to another form of social care, and then they will receive a choice in that cheaper provision of social care. So demand, there's going to be that choice, so there's likely to be that substitution. The empirical evidence also suggests that kind of substitution effect. So for the UK, there's a bit of work by Davis and co-authors, including one of our presenters later on, José-Luis, who found that increased spending in community care increased the number of days that people stayed in their own residence before moving into a care home. And similarly, for the US, there's similar levels of evidence. For example, Young and co-authors who found that for care home admissions in New York State, over time, people were having increased amount of time in their own home before entering the care home. So overall, we're expecting that there'll be a substitution between different forms of social care. So therefore, we want to kind of analyse the effect of that on what's going on. So how do we do that? Well, I've decided to have a look at the link between domiciliary care provision and if it impacts on closures. And to do that, we're using the CQC Register of Health and Social Care Providers. So the Care Quality Commission, the CQC, is the National Health and Social Care Regulator. And to legally be able to provide care as a care home in particular, then you have to be registered with the CQC. And this data source, which is updated monthly, the data set is updated monthly and is publicly available, contains information on the sector of the care home, whether it's a charity or not, the type of provision, so care home, domiciliary care, whether it's nursing or residential care, The service user registration, so you can be registered to provide services to different types of service users, be that older people, those living with dementia, physical disabilities, mental health, and so on. The CQC data also contains information on quality ratings and the number of beds, so we get kind of the size of care homes. But what it doesn't contain is a lot of information on domiciliary care provision. All it contains is their location. We don't know how big they are in terms of their number of service users they're supporting, and we don't know their market size. We don't know where their market is. All we know is where their registered location is. It also does not contain all domiciliary care providers. Not all domiciliary care providers have to register with the Care Quality Commission. For example, self-employed personal assistants who are employed directly by the person they're caring for do not have to register. So from that data set, we put together those monthly data sets to create a monthly longitudinal data set of care homes for the period October 2014 to October 2016. So in October 2014, for England, this is for England, so for October 2014, there are 11,281 care homes in England, aimed at older people and or those living with dementia. There are a lot more care homes with other specialties as well. And in October 2016, there are 11,089 care homes. So we can identify 697 closures and 505 new openings. Those closures, I should just state that they are what we consider full closures. So the service is no longer provided at the location where they are based. So at that care home, there's no longer a service provided. So changes in providers where there is a continuity of care at that care home, but the provider changes, we don't consider that a closure. We just consider that as a continuation of care. So we have a net exit rate of 1.7%, and in that 2-year period, total beds fell by 0.4%. So I can just kind of show you the net exit and entry rate. Well, exit and entry rates would give us the net exit rate. So in almost all instances across the time frame, exit rate was higher than the entry rate. We can also then map domiciliary care supply using this, using the CQC data set over time. And so I mentioned earlier that domiciliary care has increased markedly. Providers have increased. And so in this period from October 2012 to October 2016, it's increased by over 25%. And indeed, it's still going up. I think I looked for September this year, and it's up to almost 8,000 now, 8,000 providers, registered providers of domiciliary care supply. And domiciliary care supply, like care homes, is more or less available in depending on the region that you're in. So like with care homes, there are fewer care homes in the northeast, and likewise there are fewer domiciliary care providers in the northeast. And that hasn't really changed a great deal over that period of time, but other areas, such as, say, the West Midlands and London, have had rapid increases in domiciliary care provision. So as I said, we've got no idea about the size of domiciliary care providers. We just know where they're located. So how do we measure domiciliary care supply? Is simply just by having a count of the number of providers. Then we need to assess what their market size is. Again, we don't know where their market is. With a care home, it's a bit more easy. We can say, right, the care home is it's in a fixed location, so we can measure a boundary around it, create boundaries around that care home. But with domiciliary care, it's a bit more difficult. So we create 4 different market sizes based on domiciliary care, for domiciliary care around care homes. So we have administrative boundaries at the upper tier local authority and local authority district, and then we have distance weighted measures where we create 10 and 20 kilometre radiuses around care homes and count the number of domiciliary care providers within that radius. The administrative boundaries have the advantage of being linked to where funding comes from for public funding, but their problems are that they can be extremely large markets, so particularly large Shire County local authorities will have really large markets. So the local authority districts will kind of negate that somewhat, but they both suffer with the fact that they create an artificial boundary, as it were, whereas domiciliary care provision could be located across boundaries. There's not a lot of information on market size for domiciliary care providers, but past evidence has shown that there will be domiciliary care providers that will provide care in more than one local authority. So these are the 4 domiciliary care measures that we create. So the average local authority has 75 domiciliary care providers, but like with all the other measures, it has a very large spread across, and the maximum is 185, and then so on and so forth. Our preferred measures are the distance-weighted measures, and so those are the ones we prefer, given the drawbacks that I've mentioned for the administrative measures. To assess the effect of domiciliary care provision on care homes and on care home closure in particular, we need to be able to control for various factors. So we control for the following in the analysis. We control for the type of the care home, whether it's registered to provide care for those living with dementia, the size of the care home, and its ownership as a proxy for ownership with charity status. We can control for quality using the CQC's care quality ratings. So that's an overall care home rating. It's not a kind of measure of quality within the home as such for individuals, how individual quality of life, but it does provide an overall sense of what the care home has in terms of quality. We control for competition between care homes. We also then don't have information at the care home level about the needs and demands of residents and what their needs are. So we can control for them by matching in local area data on needs and demands, or proxies for needs and demand. So in particular, we use benefits data such as pension credits, disability levelling allowance uptake. We also use population measures and house price as well to kind of give us those assessments of wealth and need, likely levels of need. We then also include local area level LA expenditure per capita on residential care. So we create that from local authority level measures and then create predicted measures at local level. We use a Cox proportional hazards model, and the results, I'll just talk over the main results given time effects rather than go over everything in great detail. But for our measures, we find that for our administrative measures of domiciliary care supply for care homes, there is a negative effect on the likelihood of closure of care homes using those administrative measures. For our preferred distance measures, there's zero impact. There's no impact one way or the other. Indeed, the effect of domiciliary care, the measure DC-LAD, so local authority district level measure, is significant and at 5%, and the marginal effect is fairly strong. So every extra domiciliary care provider in a local authority district for the average care home will reduce closure likelihood by 0.8%. The other effects on closure that we find negative effects of quality, which is what has been found in past literature. Competition is positive, but it's not significant. Major providers, so that's those providing having 3 or more care homes, are less likely to close. And then LA expenditure on residential care has a positive effect on closure. So we're finding there, what we think we're grabbing there is a self-funding, diametrically opposed factors is that you've got self-funders and local authority funding, and there's cross-subsidisation within the markets, which I'm sure Ruth will discuss in a bit more detail maybe later on. So we found that there is a complementary relationship, not a substitution effect going on. So we are able to do some robustness checks of that. The first is that we're able to use actual measures of domiciliary care size available in the National Minimum Dataset for social care from Skills for Care. So that has measures of their quoted capacity for domiciliary care providers and utilisation. And this is a voluntary provision of data in this dataset by providers themselves. So doesn't cover all domiciliary care provision. Also, because of an anonymity, we can only match it at postcode district level to our panel of care homes. We find, again, using those measures, we find a negative effect on closure of capacity and utilisation, and the capacity effect, which is, we much prefer the utilisation measure. I won't get into specifics, but we much prefer the utilisation measure, but only the former effect is significant on a negative effect on closure. We also, as a further robustness check, remove dual providers that provide both care home services and domiciliary care services, and that doesn't change the results. So what do we think are driving that result? We're finding that there's a complementarity between domiciliary care provision and the likelihood of and care home provision. So what could be driving that result? Well, the first is that care homes could be focusing on clients with higher needs, and higher needs clients therefore will bring in more revenue, so therefore preventing care homes from closing. I put a question mark by that because I would expect if that was the case, we'd have found a significant competition effect between care homes. It could be the industry integration effects, that care homes and domiciliary care providers are integrating and providing the same services, working together, creating economies of scale. Again, I put a question mark with that because of that earlier robustness check. We don't find that the results don't change when we remove the dual owners of both care homes and domiciliary care provision. A likely example of where there is a almost complete complementarity is short-term or respite care in care homes. So care homes will take in people for a short-term stay. When they move back to their home, they're almost certainly going to require domiciliary care. So there would be a almost complete complementarity there. So that might be what's driving it. But we don't have details in terms of short-term care beds or long-term care beds. We only have details on number of beds. So we can't look into that in any more detail at this time. And then it could be demographic changes, but again, there might be a question mark by that because we have control for population. Implications for policy, well, this is quite good for policy in terms of the Care Act has market shaping duties and responsibilities for local authorities, and changing one aspect of the social care market doesn't necessarily impact on the other another part of the social care market. So improving or increasing, indicating you want to increase domiciliary care provision won't come at the expense of care homes markets. The caveat to that is that local authority funding expenditure in care homes has a positive effect on closure. So if the effect is, I think, is that local authority funding is being reduced and pushing down price, which then forces care homes to close. So, to conclude, we've examined the effects of domiciliary care on the care homes market. We find some evidence of a complementary relationship, which is counter to what we thought we'd find. It's positive for market shaping policies, but tempered by the effect of LA social care expenditure. And then there's a number of extensions we could look to provide a bit more detail into this work. So a primary extension would be to, rather than look at the effect of closure of domiciliary care on the closures of care homes, would be to look at their impact on price and quality. Would be a perfect example. Okay, I'll leave you with that brief disclaimer and then say thank you very much.
This talks about, it's about unlocking the data. It's about getting administrative data and working with it. So it's looking at a slightly different part of the process. I'm not actually going to show you any pictures or graphs or equations. I'm going to talk about some of the behavioral aspects of getting at the data. So I think we all know that sharing data is a very, very difficult kind of process. When Christine Borgman undertook a big study for the NSF in America around scientific sharing of data, and this covers, and she covered a number of different sciences, This was her conclusion. The dirty little secret is that there's not much sharing actually taking place. So we've seen today what the effects of BLG have been, and it has promoted quite a lot of sharing of data. But I think it is also fair to say that that has been an incredibly difficult process, and that's what I'm going to talk about today, the nature of that process. So the question is, why is data sharing so difficult, and what can we do about it? And hopefully I'll give you some thoughts about how that might work. Oops, wrong one. Let's try that one. Okay, why is sharing data, in particular around vulnerable people, usually so difficult? And the approach I want to take is to think about data sharing as a kind of behavior, and I want to bring some of the tools from behavioral science to bear on why this problem is so difficult, and then try and explain how that might help. I'm not going to get into too much detail about what we mean by vulnerable people, just to point out that there are very few truly invulnerable people. I think Superman counts as one of them. So we're all vulnerable in our own ways, and one of the complex questions is how data sharing can make some of us more or less vulnerable. So our vulnerability isn't something that happens outside of the data sharing process. Okay, a second question is, why am I talking about data sharing? My background is actually in information sharing, and many of the same things apply to data sharing that apply to information sharing. We're talking about data sharing because market exchange of data is actually very difficult. Market exchange of data around vulnerable people is even more complex and difficult. Data makes quite a peculiar kind of commodity from an economist's point of view. So a market approach to data, an exchange of data, although that happens and there are big markets for data, with regards to vulnerable people, that's usually not an appropriate solution for a variety of reasons. If we're not going to use a market solution to moving data around and gaining access to data, then perhaps we want to use a bureaucratic procedure. Instead of a market, we'd use a hierarchical bureaucratic procedure. But that's also very difficult. It's extremely difficult to create efficient, flexible, bureaucratic procedures for data sharing. So those are seen as slow and cumbersome. So perhaps we want to share data in a different kind of way. We want to have open data, and of course the open data movement, the ODI and so on, has had some success in getting certain kinds of data available to a wide range of people. But open data is often too open when it comes to sharing data on vulnerable individuals. So the traditional solutions, we can sell it, we can mandate the sharing of it, we'll mandate the transfer of it, or we can create an open data source. Those things don't work particularly well, in particular for vulnerable people. So we are left with this category of sharing data, so a voluntary kind of agreement about how we share data. And that's where some of the issues come in. So I've said something about sharing. I'll say something about the nature of data. So from my point of view, data is, in this lovely phrase that Ben Anderson, one of his collaborators, had, it's entangled. It's entangled all the way along the value chain. We'll have a look at the value chain in a moment. All the way along the value chain and beyond. So it's very difficult to extract data and share it without sharing quite a lot of other things as well. So if the data is going to be meaningful, we need to share some of the problematics, we need to share some of the issues about how the data was created and generated, we need to share a range of other frames of reference. So when we're sharing data, we aren't sharing a discrete commodity data. Generally speaking, we're sharing data and a lot of other things that go with it. Although I'd be very interested to see a little bit of some of the ideas that we had this morning about how to disentangle data for sharing, to protect privacy. I think also it's very useful to think about, we tend to have this idea of the raw data. And there's a very powerful argument in information science that raw data is an oxymoron. There's no such thing as raw data. All data is already in some sense cooked. It's already processed. It's already worked with. So data on vulnerable people is particularly entangled and particularly often cooked already, pre-processed. Vulnerable people's data, in particular, is entangled in ways that highlight power imbalances. And those power imbalances and the entanglement of the data, the complexity of the way in which it's embedded into institutions and routines and legal codes and other aspects, generates a really complex set of rules around this data. So hold on to some of those ideas. So, sharing data in the big data value chain. We often use these kinds of ideas of value chains in business schools. And I think it's interesting to look at the literature on the big value data chain, not with regard to vulnerable people, but more generally. And by and large, people produce something that looks a little bit like the figure behind me. Now, I think one interesting feature is that many of the studies of large data projects find that something like 80% of the effort goes into data assembly, data acquisition, data cleansing, and the negotiation of access to that data, the sharing of a problematic, the sharing of the data itself. Obviously, there are other parts of the chain, and I don't want to dismiss those, but today I want to focus on that front end, on where 80% of the effort in these projects tends to end up going. So, I've jumped one. So, what can behavioral perspectives tell us about why it proves so difficult to share this data? Well, there are lots and lots of behavioral perspectives. There's the theory of planned behavior. There's the COM-B kind of model that people in healthcare might be familiar with. There's a more recent development of the theoretical domains framework, which is a very large and all-encompassing attempt to think about behavior and behavior change. There are traditions from information science, like the late Mark Hepworth's information behavior kind of approach, and Christine Borgman, who I mentioned already, some of her work. There's kind of approaches more from a public administration-y sort of perspective, like the Institute of Government's mind space approach. And once again, from medical sociology, there are approaches like Carl May and Tracy Finch's normalization process theory, which I should have put on here but haven't. Now, I'm not going to try and apply one of those. What I'm going to do is I'm going to try and abstract from all of those back to 5, maybe 6 or 7, basic issues which I think are helpful in thinking about why data sharing is so difficult. And they're really 5 absolutely core traditions in social science. They're 5 kind of explanations of people's behavior. So most of them will be familiar to you. You will recognize these, but I think that they are useful traditions which all have something to tell us about why information data sharing is so difficult. And I'll say something a little bit about the last 2 at the bottom, but I'm going to concentrate on these 5. So the first kind of tradition is the notion of rules. Another thing I'll say, I come from a business school, and if you ever go to a business school presentation, we almost always have either a 2x2 matrix or we have a list of issues, all of which start with the same letter. So in my case, it's going to be the same letter. 5 R's. So, rules. So the underlying concept here is that most people, most of the time, follow the rules if they see them as legitimate and know them and understand them, which actually isn't a bad assumption about human behavior. It has something to be said for it. But for sharing vulnerable people's data, there are a number of complexities. So often, rules are seen as missing. I've looked it up and I can't find a rule that tells me what to do in this particular context. The rule is missing. Or the rule is seen as out of date. I had a meeting earlier this week where somebody was looking through their standard operating procedure for information sharing to find out whether it was possible to send an email, and they found that the whole set of rules that they were working with made no mention of email anywhere. It was still about sending letters, with the rules that they had. So Rules can be missing or out of date. Where there are rules, they can be seen as very complex. And there's often very little agreement about what rules mean in practice. If you ask a range of people in an organization about what you can legitimately share, you will often get a wide range of answers. The old joke used to be, you know, if you ask two economists for their opinion about something, you'll get 3 opinions back. For data sharing, it's the same kind of issue. You will often get very different responses from different people. So the rules aren't clearly understood, aren't clearly established. Often the response to that has been to issue additional guidance. But guidance seems to just add to the confusion. So the guidance means not only do we have to look at the rules, we then have to look at the guidance to the rules, and then we get the guidance to the guidance, and we seem to be into a kind of recess. And there's what the National Data Guardian, Dame Fiona Caldicott, has called a culture of anxiety about data sharing rules. There's a very strong culture of anxiety. So rules are an important barrier to data sharing, the lack of clarity of rules, missing rules, and the culture of anxiety around rules. The cartoon makes clear. So a second set of assumptions in behavioral science are that people, by and large, behave in role. Roles are powerful. By and large, those of us who are academics behave like academics. Those of us who are researchers behave like researchers. Those of us who are policymakers behave like policymakers. We behave in role. People mostly act in role. But when it comes to sharing vulnerable people's data or data on vulnerable people, there's often no discrete data sharing role. Whose job is this? You can compare that with business, where there has been some evolution and invention of data sharing roles, the data wrangler, for example. But often there's no clear data sharing roles. Data science roles, yes, data analytics roles, but data sharing roles, it's not so clear whose role it is. It's not even clear if it's part of any particular individual's role. How many people's job descriptions contain data sharing as part of their job role? Also in data sharing, several different roles intersect. So it isn't a matter of one person being responsible for data sharing. Often there's somebody who has to sign off data sharing, and there's somebody else who actually does it. And the level of communication between those roles is quite complex. So the role structure isn't well defined. And data sharing itself generates certain kinds of role strain, and you see people who engage in this process of job crafting, of changing their role, of trying to manipulate and shape their role, both to include data sharing, but often to exclude it as well. Not part of my responsibility, not part of my job. So roles and identities generate a set of problems. We could think about this from an economist's point of view. Economists make a very reasonable point that most people mostly respond to rewards and try to avoid risks. But for sharing vulnerable people's data, the rewards are seen as ambiguous, uncertain, and quite a long way down the line, whereas the risks are seen as proximate, immediate, and quite drastic. As per usual, Dilbert got there first. As somebody said at one of the projects that I've looked at, no one ever got sacked for saying no to data sharing, whereas they did get sacked for saying yes to data sharing if it turned out not to be the right thing to do. So rewards and risks. A fourth way of thinking about how data sharing comes about is to think about it in terms of relationships. Behavior is shaped by personal networks of relationships, social networks, and by alliances that get built up that promote but also sometimes resist data sharing between organizations. But for sharing vulnerable people's data, relationships may be missing or tenuous. They may exist at a certain level, at a high level, but they don't exist at the actual operational level, or vice versa. Those relationships take quite a long time to build up. I think many people in BLG would recognize that the relationships that they have are one of the most precious things that have come out of the project as a whole. Those relationships are very important. But in particular with regard to vulnerable people, in the context of austerity and a lot of issues and change in particular local government, those relationships and management of those relationships have been strongly impeded by constant change. So when you've built up a relationship with someone, they then leave, move, their funding is cut, they come to an end, they move. And of course that also happens on the researcher side, on the university side. So relationships form another barrier, another set of problems. And finally, and in some ways, the most powerful influence on behavior, at least if you come from my kind of institutional tradition, routines and habits. People are creatures of habit. The main way of predicting what we're going to do tomorrow is to look at what we did today and what we did yesterday. So for sharing vulnerable people's data, most routines don't include or are inimical to data sharing. Most of the routine things that we do don't include that as part of their everyday activity. And it's very difficult to establish a routine in the context of constant change and ambiguity about rules and all of the other things that I've talked about. Often the problem is expressed that routines are seen as inimical to the kind of innovation that we're expecting around data sharing and data analytics, but of course it is possible for innovation to become a routine. You know, innovation is a routine thing we do around here, although that's not easy. I'm going to add 2 more R's at the end because I think they're both important. So the first one is a rationale. One of the things that we need to share in order to share data is a really strong story or narrative about why we're sharing it. In the absence of that rationale, we won't be able to share data. But I think it's important to understand that that rationale often contains or is built on some of those previous 5 R's I talked about. But the rationale is powerful, one that convinces both parties to the sharing. You have to have a strong story to share. And finally, data sharing is not costless. It needs resources. And some of the more interesting experiments we've had have been about trying to share the cost of data sharing. So by using some of the resources that the project has had to help organizations to meet the costs of sharing, either by putting people in, seconding people across to local authorities, or in other ways helping them to meet the costs of sharing. So data sharing may imply cost sharing. So what do we end up with at the end of this very high-level discussion? So hopefully something that's quite useful, a checklist that we could elaborate. So the first question, before we start on a data sharing-based project, is can we clarify what the rules and regulations are so that everybody understands where they're at? I think people understand that, but they should not underestimate the scale of that task. That's a major task. Second, we need to define the data sharing roles, both the decision-making roles and the actual practical roles. Who is going to find this data and share it? Third, we need to think about rewards and risks and how they're perceived by actors who we are expecting to undertake these roles. Fourth, we need to make sure that we have and maintain, and where they become broken, repair the network of relationships that support data sharing. And finally, we have to see our at least long-term objective to make data sharing part of the routine ways in which our organizations work and interact. On top of that, we need a powerful rationale and a story, and we need adequate resources. But I think understanding the complexity of what that means is a practical task that everybody here, I think, has grappled with, and hopefully I've tried to encompass that in one fell swoop. And I shall stop there. Thank you very much.
Yes, I would like to talk about some of the, some key findings from a recent project that we've been working, where what we've tried to do is to share data from local authorities, administrative records, in order to understand its potential for assessing, evaluating the social care system in England. First of all, I would like to acknowledge colleagues that are part. This is very much of a joint effort. There are the names of some of the colleagues that have contributed to this program of work. And also, of course, very, very grateful to those 4 local authorities that have actually then shared the data with us for us to be able to do some analysis with it. This is just a way of showing the context of the analysis. This is just a very, very simple graph which shows the proportion of the older population in England that receives some sort of state-funded social care support. And you can see how over the period of 2005 to 2016, and the latest, there's an additional data point that is missing there that is now available, and that doesn't change the trend. There's been more than a halving in the proportion of older people that receive social care support in England. And therefore, there's very big contraction of the social care system, and therefore it's even more important that we really understand how best to use the resources that are available in order to support people with social care needs. And so just very briefly and very simply, some other key questions that we wanted to look at. It's surprising how little we still know about people with social care needs. Who are they? What sort of living situations do they have? What sort of dependency? What sort of informal support do they get? So we wanted to understand who they are, but also what sort of response is the system providing them with? What sort of care support they receive? And finally, so what is being produced as a result? Because if all we're doing is providing services for nothing without any outcomes, then clearly it's not worth the costs. So we wanted to understand, and most importantly, we wanted to understand the outcomes of the care system. And of course, then the question is, where do we get that information? Because there's very little evidence. If you use sources such as the English Longitudinal Survey of Aging, although there will be relevant questions, the numbers are so small that you really can say very, very little about the state of the social care system. Therefore, what we did was to see whether data from local authorities would actually enable us to do that evaluation. And when we look at the, evaluating the social care system from, the organization I come from, PSSRU, we often talk about the production of welfare. And so this kind of summarizes the sorts of data that you would want to collect in order to be able to answer those questions that I was talking about. And so, and not surprisingly, it's data about needs, but in social care, we're talking about people with very different needs and very different combinations of needs. And therefore, you need to understand not just their dependency, but also, for example, informal care, their housing, their living environment, etc. Services and their outcomes. And so I guess in terms of the aims of the analysis, for us, it was to try to map those 3 key lines, and then, of course, to understand the costs associated with that support. And yes, what we find is that we still know very little, in contrast with, for example, health, where there is a lot more understanding about what you get out of providing somebody with a particular treatment. In social care, there is no evidence about the outcomes of different ways of supporting people with social care needs. And the lack of understanding of that process is partly to do with the complexity of social care, we would say. Perhaps is the nature of the needs, the nature of the objectives that are being associated with that support. It's not just fixing a leg, it's also looking at people's many different dimensions of their quality of life. And therefore it's challenging, but it's to a large extent because we don't have the data. And in particular, we don't have data that follows people, that is individual level, that follows people through time. And when you're talking about long-term care, by definition, is long-term care. You need to understand long-term consequences of those. And so we engage with authorities. We just as a result of some of the challenges that were presented just a second ago, we were hoping to get data from 10 authorities. We were very grateful that we ended up with 4. I'm really happy. So, and the idea was to share, to feedback to them something that was useful for them, so that we would have a useful relationship, but also to get that data and to assess its validity. So to what extent, what data is being stored in administrative records about needs as well as services and outcomes, and what are its potential and limitations in terms of of the assessment. And so I'm just going to show you some of the data, just to illustrate some of the, and I'm not going, I won't show you all the data and for all the local authorities, just examples. And what is interesting is that actually there is a lot of data about needs, about services, and to some extent about outcomes, although outcomes is, is particularly a challenging area, that is included in those records. And actually even doing things which are very simple, like doing some sort of descriptive analysis like this of what's, this is just looking at the numbers of people in one of the local authorities we had, the numbers of people that are in the system. We basically built a panel data set matching assessment records with information about needs to packages of care to certain outcomes, and I'll talk about outcomes later on. But it allows you to cut the data in many ways, which currently it's impossible to cut the data with publicly available data. Even the local authority returns, they won't be able to, for example, show you the distribution of needs. This is just looking at all the people in the first local authority. This is happening across all of England, as I was saying before, this reduction in the numbers of people, but it also allows you to look at some of the characteristics of those people. And just presenting that back to local authorities actually was quite helpful for them. These things as simple as this. Just in this case, you can see how there are mostly people with substantial needs, as defined by local authorities, of course, and the definitions vary from one to the other. And a minority but substantial number of people with critical needs, and you see how the cut has affected mostly substantial, but not just people with substantial needs through time. Well, you can also look at the packages of care that they're getting. So, and this is, again, is very, very simple. This is still very simple. It's just looking at any one point in time and reflecting the panels that we built. What sorts of packages of care are they getting? What sorts of services? Well, it was quite illuminating. It's because this is looking at different individual services for people, for all the users in the second local authority. So home care, night home care, daycare, direct payments, meals. And you'll see how actually there are some drastic changes in the allocation of or the combinations of packages that are provided. This is data that is covering April 2010 to July 2015. Just look at the gray there. That's Meals on Wheels. You see how it was starting to go up, and then suddenly somebody saw the light and thought, Meals on Wheels is useless. Let them get it from Tesco Direct. And you see how there is April 2013, there's a big drop there. So what this illustrates is how quickly some of those policy decisions affect what people get at the local authority level. In particular in social care, because you get a reassessment every year, and therefore packages of care change from year to year. And that's quite interesting in terms of, for example, building hypotheses for evaluation. So even things like these, which are very simple, were found to be very interesting. We could also cut the distribution of cases in terms of their costs. This is focusing on people with learned disabilities. People with learned disabilities is the one group of social care users that is growing and where expenditure is growing very fast. This reflects that to some extent. This is looking at the second local authority. You see the yellow line is identifying the most expensive care packages for people with learned disabilities, more than £1,000 per month. And you see how those have grown. Well, we don't know exactly why that is. But in this study we found some very interesting evidence about their needs of those people with learned disabilities. This is, in social care, we use ADLs, activities of daily living, as a way of measuring the dependency of individuals. You see how the proportion of people with learned disabilities that are in the red or orange grows. Those are people with either 4 or 5 ADLs, so very, very dependent. So the complexity of the cases, and this is, to December 2012 to 15, that's an incredibly fast change. Well, it's interesting. This sort of evidence doesn't exist. There's no survey that gives you that sort of evidence. But then there is a question about the validity of the data that we're seeing, because this is not data that is developed for the purpose of research. Okay, so these are care managers making the assessment. So when we looked at IADLs, which are the instrumental activities of daily living, which is another measure of dependency, we saw an even bigger increase in dependency. Now, can we believe this? Can we believe that there's been this huge change in the levels of dependency of people with learned disabilities? Or is upcoding happening? Are people just, reflecting or assessing needs differently through time? And this is very important for us as academics, because we need to understand how to interpret the data in order to use it for evaluation. So on the one hand, very interesting data. On the other, some question marks about its validity. I'm just going to carry on. It's not about, obviously, just the aggregate pattern. What we wanted was to understand distributions. We wanted to understand the data at the individual level. This is just giving you a distribution of the package costs for all the people, if I remember correctly, yes, in local authority 3, for people who live in the community and in institutions. So this, in a sense, goes back to, to Stephen's presentation. And you can see how, as the care packages become more and more expensive, there's almost nobody that is in the community anymore. Then you're kind of switched into residential care that is seen as more cost-effective. It also shows you how you see that bimodal distribution of packages of care in institutions for all the people. That's residential care, that's nursing, okay? There's 2 types. Now, I'm going to show you very quickly. I need to go through this quite quickly because Paul is going to hit me in the head otherwise. But if I show you that picture for younger client groups, it's completely different. The response of the system in terms of the types of packages and the range of residential care, for example, that might be offered to people with learning disabilities is completely different. Much more expensive, but also many different types. So anyway, again, very interesting evidence. This is looking at data, so the data of people that once they go into residential care, how long do they stay in residential care? This is absolutely crucial to, for example, estimates of the cap. The current reform of the funding system is considering capping the costs, private costs, care costs. Well, this is absolutely essential information for deriving that, the estimates of the cost of that sort of policy. And actually, it was quite interesting. One of the local authorities that we were working with said we're having far too many people in residential care. Those 4 curves are telling you the proportion of people who remain in residential care once they're admitted as time moves forward. And you see how they overlap almost perfectly? So basically, the survival of people once in residential care was almost identical across the 4 local authorities, which is surprising. It suggests that actually they're not going any earlier in that authority. So these are just, again, examples of the things that we could do. But most importantly, what we want is to understand the impact of services on people's lives. And the problem, when you look at the administrative records that, and we've looked at these 4 authorities, but we also have seen assessment forms, for example, from many other authorities, is that there is no quality of life indicator, or very, very few authorities will be collecting quality of life indicators as a matter of course, as part of their assessment. And therefore, how can you map outcomes for people with social care needs in terms of the administrative records? And so we focused on destinational outcomes. So it is supposed that most people would prefer to stay in their own homes rather than going to residential care. So avoiding admission is a proxy for an outcome. So we use destinational outcomes like that. How long you survive is also another destinational outcome. And there's very little evidence about the survival effects of social care. And finally, what we looked at is changes in the needs as described in subsequent assessment forms. Okay? I'm just going to skip that. And this is just to show you that we ran some models. And these are actually the results looking at the probability of admission. So to what extent can you extend people's stay in the community by providing them with community services? It goes back to your substitution question. And what we did find is that, one, your needs are going to explain most of that variability. That's not surprising. If you've got cognitive impairment, you're bedbound, you're not going to stay in the community for very long. But we also found that services, the more you provide services in the community, the lower the probability of going into residential care at the individual level. I think you're looking at a different level. So. And so, we've been able to fit some models to look at the effects and how those effects vary across different, I can't go into the details of any of this. It's just to illustrate the points I'm making. So we are finding that using administrative records, it is possible to find some of those effects. We also looked, as I said before, and this is something that we think could be potentially quite innovative, is understanding how needs change from one assessment to the next. Because to some extent, by providing services, you should affect the trajectory of needs through time. This diagram is basically showing, as months progress from the point of assessment, whether the needs, as recorded by the system, and then of course we can talk about when are changes recorded by the system, but as recorded by the system, whether the needs remain the same, or they deteriorate or improve. So the red is the proportion that have deteriorated relative to their needs at the point of assessment. Blue is people who improve. Now, what I thought is that we were going to find no change until a year after, at least, because reassessments only take place every year, okay? And so basically there would be no information coming back to us until there's been a new reassessment. What actually we're finding is that those changes are much more smooth. The reason being is that if anything drastic happens to the person, a new assessment is called for. And therefore there is a mechanism for the administrative records to reflect those changes. Of course, there might be a delay, etc. And so one of the things we've done, so you find that amongst all the people, there is about 40% of them that deteriorate within 2 years. Is actually quite close to what you get when you look at ELSA, changes in needs within ELSA, within the English Longitudinal Survey. So that's reassuring, but also you find that some people improve. Again, that's something that you find looking at ELSA and other people. So we thought it was quite interesting and reassuring in terms of the potential for using administrative records for evaluating the social care system. These are the same sort of curves, but looking at people with learning disabilities, if I remember correctly. Now, people with learning disabilities, they've got very, very stable needs. And so it's not surprising that you find that there are very few changes and little deterioration through time. Again, reassuring. And then we did fit some models which try to understand the extent to which, if you had given more services at the point of assessment and controlling for your needs, that trajectory would be affected or not. And we did find, in particular for home care and direct payments, that the more home care you get, the more direct payments, the better you're going to be in terms of your needs at your next assessment, if you're an older person, not if you're a younger client group. But that's what you would expect, because, as I say, there's very little variability for younger client groups. So we are finding some beneficial effects, which is quite exciting, I think. So some conclusions. And apologies for going through so quickly, but I just wanted to cover more, I guess. I could have just focused more. So some conclusions. I think, from what we've learned, the administrative records have got a significant potential for helping us understand certainly the characteristics of individuals, but also what works, which services work in terms of improving the quality of life of people. So great potential. I think we need to do much more work. However, first of all, we still need to understand the validity of some of that data. And going back to, are ADLs, we know that ADLs and IADLs, as recorded in these assessments, are not comparable with the ADLs and IADLs we get from other surveys. And so we need to understand how to interpret these. Typically, care managers will not record things which, although there might be, for example, a health problem, that health problem is not recorded if it's not important for the case in terms of social care. And so we're working with care managers in order to understand how they record this data, in order to better interpret it and better use it for evaluation. But also, we need to improve our methods for using this type of data. This is not experimental data. This is, it's difficult in terms of the methods that we need to be applied, and we need to improve these methods for evaluation. Then there are some big data gaps. This study was 20 seconds. So this study initially was going to look at prevention. Now, some of those preventative interventions are not recorded typically in current administrative records in social care. Self-payers, by definition, are excluded. So there'll be lots of people with some social care needs that are excluded. And as I say, outcomes, information on outcomes in terms of quality of life is very limited at the moment. Different local authorities have got different assessment records, and therefore it's very difficult to compare the needs using administrative data at the moment. And then finally is the point about IG. I mean, just to manage to get the data shared is really, really difficult. For some of these authorities, it took us almost 2 years when we had a project that was going to last 3 years. So there's your 80% almost. So just that effort is massive. Thank you very much. Really, really difficult. For some of these authorities, it took us almost 2 years when we had a project that was going to last 3 years. So there's your 80% almost. So just that effort is massive. Thank you very much.